And what I thought I would focus mostly in the next about 15 to 20 minutes is give some definitions, talk about the criteria that we use for brain death. Again, not going too much into the details on actually performing it, but also talking about donor management, predominantly how can we optimize the donor and also the organ that we are actually retrieving from these donors. So that's what I would focus on. I would like to start with acknowledging Dr. Ramesh Venkataraman, who is one of my colleagues whose slides I've liberally borrowed. I've spoken with him about that. And also all the families who have actually made organ donation a reality. I would like to start with an acknowledgement on before I move on. Now, about brain death, and again, there are probably more questions than answers that we would have in this session. There are certain things that are very clear. What should we do? What are some preconditions before you even test a patient for brain death? Is that you should ensure that there is a good reason to believe that the patient is brain dead. And that could be from imaging, where you may have large, head injury patients whom you encounter in the ICU, or it could be clinical reasons where there is a reason to believe that there was a witnessed cardiac arrest and there has been a period of hypoxia subsequent to which the patient is fulfilling the criteria for brain death. It's important to ensure that the patient is not hypothermic, so we need to make sure that the temperature is more than 32 to 34 degrees. And more importantly, no confounding medication use or drug intoxication. And again, sometimes getting this history may not be easy, and if in doubt, it is always better to ensure that appropriate screens are sent, because most of the patients, when they come in unresponsive, the families may not be able to give us the kind of history that's required to make this diagnosis. In addition to this, lab testing that we do to ensure that there is no metabolic abnormalities, no severe electrolyte abnormalities that are actually causing this brainstem dysfunction or brain dysfunction. So what are the clinical criteria that are essential before we proceed to confirming brain death? Of course, the patient is comatose, unresponsive, but more importantly, does not have any motor response, no response to painful stimulus, there's absolute absence of motor response, absence of all the brainstem reflexes, and without going into major detail, certainly looking at pupillary light reflex, absence of corneal reflex, doing the Dolce movement, absence of oculocephalic reflex, any absence of oculovestibular reflex, which we do by the caloric response. And of course, the most common thing that we do at the bedside right away is looking for gag reflex and cough reflex and ensuring that they are not present. One thing that I did want to focus on is on the apnea test, which needs to be done appropriately and needs to be done by the clinician, the consultant who is actually declaring the brain death, rather than just letting someone else do it. We have to ensure that first the patient is appropriately pre-oxygenated with 100% oxygen, at least for about 10 minutes before you do the apnea test. Check a baseline blood gas that needs to be obtained first, and then disconnect the ventilator for about a minute. And then while you're doing this, it's not only important to obtain another blood gas, but you need to be observing the patient, uncover the patient, and check if there is a complete absence of respiratory movements, that the patient is remaining apneic, and subsequently get another blood gas where you expect or want the carbon dioxide to be above 60 millimeters of mercury, or increase 20 millimeters from the baseline that you have obtained in the first blood gas before proceeding with the second part. Now, most of the time, this is a question that we have: is clinical testing enough, or do we need to have supportive diagnosis with ancillary testing? And again, some of our institutions may have the capability to do all of this, some of us may not be able to do this. Even something which may sound as simple as a bedside EEG may not be practical in some of the situations that we are dealing with. So one thing I want to specifically say is ancillary testing is not mandatory. It is just to support your diagnosis if you have any questions about your clinical signs and symptoms that you have made out. In the EEG, of course, the thing that we are looking for is the so-called flat EEG, and there are specific criteria settings that the neurologist would be able to interpret for the brain death. But the one thing that may complicate it is if you are having a barbiturate coma, then this is not the EEG there is not going to be helpful, and therefore we may probably have to not use this criteria for making the diagnosis of brain death. Other tests that are used are predominantly to confirm the absence of blood flow to the brain, and this could include anything from a transcranial Doppler, which theoretically could be done at the bedside in some of our institutions, using catheter angiogram, MRA, CT angiogram, any of those to document the absence of cerebral blood flow. And again, a SPECT scan can also be done, which would confirm that there is no isotope uptake, which again confirms brain death. Now, I just wanted to have that brief overview on the brain death before we actually move on to the organ donor management, which is the predominant focus of my talk. All of us should be aware of this Transplantation of Human Organs Act from 1994, where it was defined that a deceased person is someone in whom there is a permanent disappearance of all evidence of life by reason of brain stem death or in a cardiopulmonary sense at any time after live birth. Now, as much as this is clear, I think everything is a matter of interpretation on whether the glass is half full or half empty, and we have the same issue here, whether this definition can be only used to organ donors, or could we apply this to any other person where we know that the patient is brain dead, and can we theoretically say that the person is dead and withdraw life support. Now, to take this one question at a time, can this definition be applied to non-organ donors? Ethically and scientifically, absolutely yes. Legally, and I think it's quite certain that you could use it, and brainstem death is death, and that's the way we should project it to the patients' families when we are discussing, and I will mention that in the subsequent slides. Do we need government certified, for lack of better term, brain deathologists? I mean, again, here there is a variation of rules between states, so we need to be aware of our local state laws. Like in Tamil Nadu, where I live, there are accredited people who can actually certify brain death, and most of them are neurologists and neurosurgeons. Now, we have represented from our own institution and several others, and now intensivists are included into the panel of those who are accredited to declare brain death. So you do need one, particularly if the patient's family is consenting for organ donation. We do need certified brain death specialists or accredited people to do it, at least in our state, and I'm not familiar with the rules in each of the states that we are dealing with. Can you withdraw care if the family agrees? And here again, the question is, if they are donating organs, if they are willing to donate organs, I think the answer is fairly clear, where you say that you are going to go ahead and declare brain death once the second person has confirmed the brain death, and then you can withdraw and you can take the patient to the operating room for retrieval of organs. Now, the big question comes, if they don't agree for organ donation, are we allowed to withdraw all life support? And again, ethically, I think yes, because without any doubt, and as you can read from the Transplantation of Human Organs Act, certainly they qualify as dead. Brainstem death or cardiopulmonary death is death. And legally, again, I think there is a stand very clearly that if the family wants to withdraw, once they have been certified as brain death, I think it's absolutely appropriate to go ahead and withdraw life support. There's a long waiting list, not only for organ donation, but also to be brain dead. As you can see, all those people on two-wheelers without helmets, okay, potential future organ donors. Okay, so why really bother about donor management? One, because I think the most important thing is the time from brain death to organ harvesting. And again, there can be logistic reasons why this is getting delayed. Like it could happen middle of the night, where there could be 12-hour delays, or family members may not be immediately available, and a lot of logistic reasons can happen. And during this time, we must understand that there is progression of brain death to also somatic death. If the organ or the tissue is not appropriately perfused and maintained, these may not be retrievable organs. And I think it's important to ensure that that period is managed appropriately. Converting the unsuitable organs to suitable, again, by appropriate management, you could And again, a lot of it depends on the surgeon's aggressiveness as well. I mean, there are surgeons who would probably accept a moderate liver or a moderate lung, whereas others may not be willing to do. And it's important to understand, their reasons for accepting or rejecting an organ. More importantly, we need to try and see whether by doing this appropriate donor management, we can increase the number of organs that are being invested or harvested per donor. It doesn't have to be just the liver or just the kidneys. There's a lot more, and a lot more tissues can be used as well. And it has been clearly shown that appropriate hemodynamic management of the donor clearly alters the allograft outcome, once the recipient gets it. So what all do we do to the donor? Number one, of course, from a hemodynamic standpoint, you want to optimize the preload, you want to optimize the contractility, and by that I mean giving them appropriate amount of fluid, ensuring that the blood pressure is maintained, ensuring that there is appropriate organ perfusion. Again, using pressors, you could use a single vasopressor, but now there's increasing evidence to show that using a combination therapy, using two pressors may be easier and better to maintain the organ perfusion. But it's important that when we are giving fluids, we need to balance the lung and the kidney, and flooding the lungs may not necessarily be good for harvesting the lung. But on the other hand, if you don't appropriately perfuse the kidney may not be harvestable, and it's important to balance. While we are dealing with these patients, after declaration of brain death, it's possible that they have arrhythmias, they could have bradycardic episode. But we have to remember that atropine is not going to work on those patients, and it can be an issue. Respiratory management should include, again, not on all patients, but as appropriate. You need to give them bronchodilators when appropriate. You may have to do a bronchoscopy. You may have to send BAL for looking at the secretions. All of that needs to be done while you're awaiting the process, suctioning, appropriate lung recruitment, and more importantly, managing the ventilator appropriately. And I will share with you the protocol that we have from Apollo Hospital towards the end, incorporating all of these. What else? Electrolyte abnormalities, particularly hypernatremia. It's important to recognize diabetes insipidus early, treat it with DDAVP as appropriate. Need to give them fluids, but try and avoid hydroxyethyl starch, primarily because it has been shown to cause coagulation abnormalities and also renal dysfunction. We need to give them the so-called triple hormone therapy, or the 3 hormones that are used, and again I'll show you the protocol that we have subsequently, using thyroxine, using hydrocortisone, and vasopressin. In addition to this, we need to provide appropriate supportive care, ensuring lubrication of the eye, closure of the eye, NG tube aspiration is appropriate so that there is no gastric distension, and ensure that their temperature is appropriately controlled by using warming blankets as appropriate. Very important to be counseling and talking to the family on a regular basis while you are doing this, because it's not uncommon for families to complain that everything went well until they gave consent for the organ donation, and subsequently they have not really been briefed on when they would be taken for surgery or when the body would be given to them for cremation or for further care. There are significant barriers when we want to do this. Of course, everything when it comes to cost, we do want to address on who is going to bear the cost of this entire management in the ICU, the additional time in the ICU, the drugs that are used, the devices that are used, all these additional tests. Should it be billed to the patient who has, patient's family was actually consented to donate the organs, or what needs to be done? And again, this can vary from institution to institution on how exactly they handle it. In our institution, the patient family is not charged after they have been declared brain dead. Resource utilization, it again, involves intense nursing. Once you're declared brain dead, doesn't mean that the process is over there, because a significant amount of nursing involved, doctoring involved until the organs are harvested. Of course, there's the time factor when we are utilizing the ICU bed, and also how long it's going to take to get them to the surgical theater. Staff education, training, a lot of it on care provider attitude. Sometimes even we hear that the registrars, once they are brain dead, are not doing tests as quickly as on other patients. These kind of things need to be addressed. family bereavement, and if you don't have protocols, it can be an issue. I hope this works. I just wanted to share with you our protocol that we use for managing a potential organ donor, and I think having something like this ensures that everybody is on the same page rather than being practiced differently by each consultant or registrar who is around. So we have our goals stated, how to achieve hemodynamic stability, optimize the organ perfusion. For the temperature, what's the goal? Monitoring the temperature. If the temperature is less than 35, use rewarming, and we use an equipment called variotherm, which can adjust the temperature. Hemodynamic support, we have our goal stated, what the CVP should be, what the blood pressure should be, urine output should be, and here we clearly state, place a central venous catheter and preferably internal jugular, and monitor the central venous pressure. Use fluids, preferably crystalloids or sometimes colloids as required. And our vasopressor choice, usually we start with vasopressin 0.5 to 2.4 units per hour, and also in addition to dopamine. If we are requiring more than 10 mics of dopamine, then we switch to noradrenaline. The hormone replacement therapy, again, we have the protocol on using insulin infusion to ensure that the blood sugar is between 150 to 180, vasopressin, levothyroxine, 20 mics bolus, and then an infusion to be started, and also methylprednisolone. When do you suspect diabetes insipidus? If the urine output is more than 4 ml per kilogram per hour, or the sodium more than 145, and the urine osmolality is less than 200, in which case we go ahead and use desmopressin 10 micrograms spray into each of the nostrils and repeat it every 4 hours. Electrolyte management clearly stated on how to adjust for the sodium levels. When do you give IV fluid bolus? What lab tests need to be done? What kind of viral package should be sent? Daily labs. And then, most importantly, complete death certificate, death summary, corporation forms, all of those. And we clearly state that the time of death is the time of the second brain death declaration. So all this is incorporated in our protocol, and even once it's completed, the two people who are declaring the brain death have to sign here. It's the checklist that we have on actually performing the apnea test, the cold calorie test. When was the first declaration done? When was the second declaration done? Who was the doctor who did it? Whether the serology was sent, were all your goals achieved, were all the death certificate, everything completed, and did the family consent for, where did we obtain the family consent for organ donation, and whether the transplant coordinator was informed. Okay, lastly, not to forget, discussing with the family, as far as possible, avoid using the term brain dead, and this is something we are learning from our experience. Just say the patient is dead, and which is the reality. I mean, that's what we were talking about right from the beginning, because that's when you confuse them when you say the patient is brain dead, and you need to explain that the person is dead, but the lungs and heart are actually being pumped by the machines and lungs. Machines and drugs that we are using, and I think that's the kind of comfort they need to get before they actually agree for organ donation process. Explain how you actually know that the patient is dead, and you have to tell them what tests you have done, what have you found to say that there is actually no life, and that there is no way that the patient is going to breathe if you get them off the ventilator. And I think a lot of it is the style of explaining to the family that's going to make all the difference. If you are asked, explain that you are not actually withdrawing the life support, and you are simply removing the medical equipment from a dead person. And I think this is something, that's the kind of comfort that they need to have, saying that you are not just withdrawing because they are asking you to, or because you want to retrieve the organs, but they should understand that the process is being done because clinically the patient is dead, and all you're doing is removing the equipment from them. More importantly, and this is where, as I was mentioning, you need to give them realistic idea on the approximate time frame of how long it's going to take for this entire process. When do you think that the patient is going to be taken to the operating room for retrieval of organs, because it involves planning from their end, but more importantly, they need the continued psychological support during that period of time to move on. What do we expect in the future? Number one, I think the name should be changed from Transplantation of Human Organs Act to Transplantation of Human Organs and Tissue Act, because really I think there's a lot of other tissue that can be recovered and should be recovered, which we are probably not appropriately focusing on. The term near relative, which currently includes spouse, brother, sister, should probably include grandparents, grandchildren, because we are seeing more younger people needing transplants whom the grandparents, if they are brain dead, may be able to donate their organs and vice versa. It should be made at some stage mandatory to request families of brain dead donors to go through the organ donation process, because a lot of the times now it's sometimes up to the consultant to decide whether they want to request or not, and I think making this mandatory can make a big difference. Having a central record keeping and hopefully at some stage form a network for organ sharing across the country, very similar to the US model or any of the Western models. And more importantly, increasing the panel of people who are actually authorized to declare brain death. And this is where, our involvement and ensuring that intensivists are added to the panel would make a big difference. Whenever we say transplant, I think India has had a lot of negative reputation in the past. I mean, there have been reports of Chennai being a kidney bazaar and stuff, which I think there are a lot of negative connotations when we think about organ donation. And I think we have come a long way from that. Our ethics and the way things are done and the way the processes have been put in place is significantly better. But I think it's also equally important to understand that penalties for offences could be very significant, and I think we need to have formal guidelines, establishment of network for organ sharing to accomplish all of this. I'll close there, but I would like to take this opportunity to invite you all. On an annual basis, we do an advanced critical care symposium, and this year our focus is on critical care nephrology, and you're all welcome to it. Thank you.